I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. And I'm really excited to have as our guest today, Sidney Haitoff. Sidney, how are you doing today?
I'm doing well, Demetrio. Thanks for having me. How are you?
Oh, it's exciting to have you on board. Thank you. I'm doing great. So, before we dive into the question of the day, tell us a little bit about yourself. Tell us what you're doing these days.
So, Sidney Haitoff, co-founder, CEO of a company called Mishe. Mishe is building a health plan operating system that automates claims and collections for patients, providers, and payers. We are a startup, tech startup, and working to eliminate the $1 trillion in estimated waste that is plaguing our healthcare system and making it harder for people to access care, making it harder for doctors to render care, and keeping us from reaching the heights that we should be hitting here in 2024 from a clinical and a financial efficiency perspective.
Awesome. So let's just hit it hard. What's wrong with the system that we have right now? I mean, we could talk about that for hours, obviously, but let's encapsulate.
Yeah, in one word, I would say middlemen. It's the process that by which doctors are paid, and the process by which we transact medicine, not just financially, but administratively and even in operationally and in some instances clinically. Convoluted process whereby to access care for any individual, people believe that they need to have insurance or have some type of coverage, insurance coverage, and essentially insurance coverage where that used to represent a way to shield people from financial ruin resulting from healthcare that they need. It's turned into a barrier to care. The coverage has essentially gotten in the way, if you will, which is wild. And so that is a large part largely in due to the process. And so I think we need to get back to the basics and allow for individuals to communicate, exchange directly with providers, doctors, facilities, et cetera. And the same with employers. If we have an employer-sponsored system where most people receive care and health benefits through their employer, we need better mechanisms through which to enable employers to provide those benefits in an equitable way to get a better understanding of what the benefits are and eliminate a lot of the confusion. If I had one word to sum up the problem, I would say middlemen, and if I had two words, middlemen in the process.
Sure. So what's wrong with the middleman? I mean, obviously you and I have had this conversation lots of times before, but a lot of people in our audience aren't familiar with this. So how are the middlemen the problem?
The middlemen in our healthcare system have a financial incentive to generate profit. The alignment, there's misaligned incentives. There is no alignment between the middlemen who are supposed to be helping people receive care, facilitating care. They are really incentivized to generate profits for their shareholders, right? These are for-profit entities, public companies, and their entire reason for existence, at the time that they became, public companies, is to generate profit for their shareholders. And so, at its core, at their core, the alignments, the incentives don't align, and so they will always be working to maximize profits, and that will always come at the expense of patients and providers. And I would say that's the core of it. Is if we are able to align incentives better and create a model where providers are incentivized based on the health of a population, that members and patients, individuals, anybody is incentivized to maintain their health and get healthier, we would be in a much better position financially. 16, I think it is percent of our GDP is going to health care costs, and keep me honest with that number, but we're wasting a lot of money on inefficient, ineffective care that is resulting from the middlemen in the process of the misaligned incentives. And if we can fix that core issue, which I'd love to dive into how or the way that I think that the Consolidated Appropriations Act and legislation that was put in place actually works to fix that issue. But fixing that issue, I believe, would go a long way in fixing the overall problem.
I'm glad you brought up the Consolidated Appropriations Act, because when I first learned about that at the Free Market Medical Association conference, it blew my mind. But a lot of our listeners may not be familiar with the Consolidated Appropriations Act. So what is that? How does it play into what you see as the beginnings of a solution to these problems?
So high level, and I'm going to keep it super high level because I know enough to be dangerous, but I don't want to be quoted on the super specifics. But it essentially, the Consolidated Appropriations Act is a legislation that holds employers responsible for their fiduciary duty, fiduciary responsibility that they have to act as a good fiduciary on behalf of their employees. And what that means is, in the context of healthcare, is providing employees with a fair and equitable health benefit that doesn't leave them in financial ruin, and that actually guides them to health and guides them to value. We're in a system where, like I said, the incentives are misaligned to the point where the entities that are responsible for enabling care and facilitating care, they are incentivized to generate profit and essentially, at the expense of members. And employers are the number one buyer of those health benefits in our country. And so they are kind of squarely in the middle of this misalignment, where they are feeding into the broken system, if you will, and perpetuating the system of misalignment, where they could fairly easily put an end to it. And there are reasons why, employers, people say that employers have kind of turned a blind eye to health benefits, and people refer to what's going on in the healthcare industry as employers writing a blank check to a third party to go out and spend whatever they want, essentially, on health benefits, at the expense of their own bottom lines, the bottom lines of their companies and of their employees, who are ultimately paying for those benefits in the way of lost wages. And so the Consolidated Appropriations Act holds the employers responsible for being more involved in choosing the right benefits, the appropriate benefit structure that doesn't subject their employees to financial harm, financial toxicity. The healthcare space and our U.S. healthcare system is known for being able to address the most complex clinical problems and issues, and being able to navigate the complexities or the deepest, if you will, of clinical toxicity. And deepest isn't the right word. Navigate the worst case scenario from a clinical toxicity perspective. But we are the worst, literally, of all modern countries, OECD countries, with regards to eliminating and limiting financial toxicity. And so the Consolidated Appropriations Act is a piece of legislation that essentially requires that and holds employers responsible for making sure that the benefits that they provide are sound. And if they don't, then it gives employees a mechanism through which to hold their employers accountable through lawsuits and the like. And we're starting to see some of that with this year, because I believe there was a provision of the Consolidated Appropriations Act that took place on 1/1 of 2024. And it's resulted in a number of unprecedented lawsuits where employees are suing their employers for the benefits that they've been subjected to. And I want to just take a quick sidebar. This whole concept of employees and benefits and the employer being responsible, it all stems from the fact that when an employee is enrolled in a group health plan on behalf of their employer, they're locked in to that health plan. They don't really have much of an option to access health insurance and coverage outside of the health plan. And so essentially the employers are handcuffing, or employees are handcuffed to their employer to a great extent. There have been initiatives that have been put in place, like ICRAs and the exchanges that give employees and individuals an alternative option with regards to accessing care. They've, for the most part, fell flat. But and group coverage is still, by far the largest and most predominant method of coverage. So in effect, the employees are handcuffed to their employer, and employers are leading them into the fire, and leading them into these dangerous financial situations that leave a lot of people, if not a ruthless amount of people. I think they, at one point, 1 in 3 people carried medical debt, and the largest, the most common reason for bankruptcy in our country stemmed from medical bills. And so that largely comes from and stems from our the misalignment in our system and the benefits that the employers are making available to their employees. And again, to kind of bring it home, the Consolidated Appropriations Act holds the employer, or provides a mechanism, a road through which the employees can hold their employer responsible and challenge the benefits and challenge the status quo. And we're starting to see the benefit, pun intended, of that already. Some of the lawsuits, like Johnson & Johnson and the Walgreens suit I saw recently. Chris Deacon wrote a post about $100 million class action lawsuit. I believe it was against Walgreens. I don't know if the employer played such a role in that suit, but I think we're starting to see class action attorneys rushing to the space and seeing healthcare as an opportunity to help the public challenge the norms and challenge the status quo. And so, it's starting what seems to be, and what I believe will turn into, a bit of a revolution. And so I'm here for it.
Well, I think that's kind of an understatement. This is the beginning of a huge revolution. And, in fairness to a lot of the employers, I'm an employer myself, and obviously you are as well. Up until recently, a lot of employers were themselves handcuffed by their benefits advisors or their TPAs or their brokers, because they said, this is how much it's going to cost. And the employers would ask, well, wait a minute, can you break that down for me? Can show me the data? And they're like, nope. You're not getting that data. You just have to trust us. And now with the changes in the law, with the CAA and other provisions, we see that the employers now have a shield that they can use against those people that are trying to take advantage of them, and say, you know what? The law requires you to show us this information. And if you're not going to, I'm going to go talk to somebody else that'll show me how I can save this money. And we're starting to see a lot of companies like yours, as well as others like Self-Fund Health, trying, I think in many ways successfully, to say, okay, let's remove these barriers. Let's give you transparency so that you can know this is what you're actually paying, so that you're actually meeting your fiduciary duty to your employees and your beneficiaries. And so I think that makes a nice segue into what you're doing. So tell us, what are you doing? How are you guys addressing these questions? How are you eliminating these barriers? How are you creating that parallel ecosystem? Because we talked about this before we went on camera. Many times the only way to fix a system is to just turn your back on it and build a new one. And that's what you're doing right now. That's exactly what you and other people like you are doing. And I think we want to hear more.
Yeah, amen. Happy to dive in. First thing, though, I want to kind of just set the stage with the concept of or definition of benefit and what essentially makes up a health insurance plan and a health benefit. And there are a few components that we'll dive into in the context of what we're building with Mishe. And I just want to kind of touch on a few key ones as some of those or a couple of those are top of mind for a lot of key people, key influencers. And I don't mean social media influencers. I mean influencers in our space, people who are putting a lot of money and resources behind certain initiatives that will help further the movement. So to me, the benefit is made up of you have prices for care, you have the care itself, the network, if you will, the pricing or the contract rates. You have the money that gets paid for claims. You have the claims themselves that represents the transaction, and you have risk, the insurance component that helps offset against instances where the cost of care might exceed the money that's paid towards the benefit by any individual. The concept of risk, the thought is that the larger the risk pool, the larger the number of people that are in any risk pool or in any group, if you will, any sample, then the easier it is to spread risk across the population. And so, the more people that you have in a group, the larger the pot of money, and the more money there is to spread across, a higher cost instances or events. And there are a number of additional components that are involved, but yeah, I like to kind of call out those key things, and even to distill it one step further, I would say you could refer to it as the network, and that's the prices and the providers, the transaction, and that's the billing and the claims and the collections, and the money, and obviously the risk on top of that. So Mishe, we built a what we're referring to as the operating system to help or for people to help navigate health plan, health benefits, and health care. And we're focused initially on helping solve the problem of the health plan and navigating the complexities of the health benefit. But it's part of a long roadmap for instilling and implementing and affecting major change with regards to how we access and find and pay for care, and also how we live our lives. We want to eventually get to the root of what's driving health. But initially, the first point of attack, first place where we have to fix the problem is the cost of care and the ability to receive, or the ability to access care and to do so, or to access care from high quality and high value providers. So we started initially with a network, and actually, let me take a step back. I'll give you a quick background on me, and then I'll kind of give a sense for where I'm coming at with this. So I grew up in a medical billing household. I work with a lot of docs, and a lot of you guys come from doctor families. I came from a billing family, very not sexy at all. My dad worked with a number of orthopedic surgeons, radiologists, facilities in the Northeast region, New York, New Jersey, Connecticut, and wanted nothing to do with that business growing up. I went to school for finance, and I was a little bit of a software nerd back in the day, or I guess still am. And he insisted that I come check out what he was working on after I got out of undergrad. So I did that and saw firsthand the inefficiencies of our healthcare system and really the inefficiencies of the transaction. We billing company, and people refer to, and I refer to the transaction as billing and collections. It's the process by which healthcare treatment is invoiced. So the service provider invoicing the payer or the sponsor, whoever's paying for the care, and then the process by which that care is paid for or reimbursed. It's currently a $100 billion industry. The medical billing space, revenue cycle is the sexier term for it. Can't believe I just used revenue cycle and sexy in the same sentence. But yeah, it's $100 billion because of how convoluted and complex it is. And that's something that I saw very early on and wanted to fix. Right, I joined the space in the wake of Grubhub and Groupon being released back in the late 2000s, early 2010s, and saw the power of modern payment technology and transactional infrastructure. And when I stepped into my father's office, into that space, it blew my mind how we were stuck in the early 90s from a technology perspective there. I wanted to create a company that would facilitate a faster transaction to get doctors paid quicker. That was our whole job, is to get docs paid faster, and with our best foot forward. And we were very good at the job. There are still claims that take 3, 6, 9, 12, 18 months to get paid, and that's on a service that you already rendered. Right, like nowhere in no other industry does the service provider have to wait a year to get paid on a service that in many instances is life-saving. And I mean, life-saving, whether it's you're helping someone get out of bed because they've been bedridden with back pain, or life-saving because you're curing cancer. There shouldn't be a year timeline, a year lag between payment or for payment in that context. And so, I just wanted to create a faster way. And having seen the modern payment technology in these other verticals, it seemed like a no-brainer to me that we could apply some of these, what at the time and even today are standard technologies in the context of one of our largest industries, and an industry that essentially is a matter of life or death for people. It's like it should be an afterthought. It should be table stakes modern payment technology to make sure people are getting paid. So that was the initial impetus behind Mishe, is to create a better mechanism for which doctors could get paid. And I saw also early on that I was the only one of my friends and peers, family. Well, I guess not my family, but only ones of my peers that knew what the true cost of care was. Surgery, and I'll use a carpal tunnel can cost $2,000 instead of 20. Knee replacements should cost $20,000 instead of 80, or 100 in some instances that they're billed. And I'll give you a story. The reason I had the idea for Mishe 2 years into my career, been in healthcare my entire career, 12, 14 years at this point. And had the idea early on, wasn't ready to start a disruptive, kind of scary company like Mishe back then, but used the time to become an expert in the space and make sure that when I was ready, that we would be able to put our best foot forward. I fast forward 10 years, I thought that someone would build the company that I had always envisioned, and that I had spent more time in my head thinking about, year over year, and almost obsessing over. And no one built it. These telehealth companies came out. I thought, okay, they're making it easier to access meds and telehealth services. Like, that's the start. It's coming after. They're definitely going to do that right after. And no one did. And so when the price transparency rules that took effect, in 2021, when they started to become socialized, back in like 2019, 2018, I was like, okay, this is it. Like, if I don't do this now, then someone's going to, and I'm going to have a lot of regret. And I'd seen or had ideas in other industries and seen those things come true, and I had just gotten sick of thinking what if, and so I was driving cross country. I had just built out a team for a spine group that I'd started working for, and driving cross country, and I heard a podcast on the daily speaking about a mother who was facing bankruptcy because of out-of-pocket costs that she needed to pay on top of her premium for her child's spine, kind of last-minute spine surgery. And I was, deep in the spine space. I knew exactly what procedure based on the description that they were giving to the case, and knew that the true cost of that procedure, if you want to use Medicare as an anchor, using a percentage of Medicare as the prevailing pricing methodology for any insurance carrier, and people call that concept RBP, reference-based pricing, but that's the prevailing price methodology across the industry. It's not just RBP. Contracts are written at percentage of Medicare, and it's been that way since I entered the space back in the late 2000s or late 1000s. So I knew based on what the code was and the procedure, and I knew what it would cost. And she was talking about a dollar amount that was far and away more than what it should have been, and so an inflated price. And it was a price and a balance that was, she was facing bankruptcy. This is a hardworking single mother working in a factory, and working to put food on the table for her kids, and having a hard enough time doing that because of the premiums that she was paying to make sure that her family had access to adequate care. Now, when she actually went to go use the benefit that she'd been paying, hundreds, if not over $1,000 per month to access for her family, now she has to pay on top of it. And it highlighted a dynamic that I've seen and kind of come to internalize frequently, where we were in a place, and we are today in a place where people are paying first and last dollar for care on top of the premiums that they're paying. People pay $700, $1,000 per month for an individual for access to coverage, and then they have a deductible that then they have to pay another couple or a few grand out of pocket before insurance pays for anything. And so in effect, we're talking $10,000, $15,000 per year for an individual to pay before they get access to any care, or excuse me, before the insurance carrier pays for anything in the way of care. We call that, essentially functionally uninsured, where, because most people don't ever come close to hitting their deductible, they are essentially uninsured because they're paying for everything out of pocket. Those premiums are essentially being paid for access to discounts. And the reason why I'm saying all this is because those discounts that most of the country, frankly, is paying thousands of dollars in premiums to access, and then never getting the benefit of the insurance carriers paying anything towards their care. That's just a function of information, right? Mm-hmm. The Medicare rates are public. You go to CMS Medicare fee schedule lookup tool, and you can find the price of any service under the sun. It's just a matter of knowing to do that, and it's a matter of it being easy, and that function being easily available and accessible for individuals, and it's just not. And my point in saying all this is that I saw, I thought it was wrong that I was the only one that knew how to find that information. And in the age of Grubhub and these marketplace platforms, like, I wanted to create one for healthcare because maybe the ability to pay or access that discounted rate, in making that public, maybe giving people the ability to access that discounted rate would unshackle them from the expensive health benefits that they were otherwise paying thousands of dollars just for those discounts. And so at its core, and sorry, this is a long way, but I want to give you all the context, a long way of giving the reasoning. At its core, we wanted to make it easier for doctors to get paid and easier for patients to know what the real cost was. And so we built a marketplace, And early on, it was a basic marketplace where doctors could post their prices for services. Initially, it was basic ancillaries, office visits, X-rays, injections, etc. I saw fairly quickly that doctors were concerned about anti-kickback, Stark, and dual fee schedule concerns, where doctors don't get the same safe harbors that the PBMs get in the way of discounting treatment or discounting treatment for cash payment. And I'll say that a different way is, PBMs, pharmacy benefit managers, they get the ability, they get a safe harbor from the Stark and anti-kickback that protects them against being seen as inducing patients by offering discounts for drugs, cash discounts for drugs. Doctors don't get that same benefit. And there are some states where, like Texas, that state that if you charge a different price for the same service to different people based on their insured status, that not only represents insurance fraud, but it's a misdemeanor offense. And so started to see that docs were concerned about that concept. And so realized that, okay, we needed to build a network. We need to build a legal apparatus through which that doctors can actually engage in this cash type transaction. And so we built that network. And so at that point, we had the marketplace, i.e. the transaction infrastructure, and then the network, i.e. the mechanism through which we were able to lock in discounted prices and build an inventory of care. Right. And so at that point, that's two of the three of the trinity, if you will, of medical benefits. And the next part is you need someone to pay for it. And so I at the time, this is about a year ago, I didn't have as much or really any exposure into what I call the buy side of care, the benefit side of care. I came from a life of the sell side of working with docs, like such as yourself, and surgeons and patients, and never really understood the benefit. I understood EOBs and SBDs, summary plan description, in the context of making sure and fighting for patients to make sure that, fighting for providers and fighting for patients to make sure that services were covered appropriately, so that they weren't subject to financial ruin because an insurance carrier decided to deny something for no reason. But I didn't have the knowledge of the buy side, and so we went out into the marketplace serving consumers. We had a partnership with WebMD, and we made the services, the inventory that we were able to gather in New York is where we started, New York City. We built out a network of surgeons across a few different specialties. And I was able to use my experience to bundle those surgeries, because I had that experience bundling surgery in the context of the personal injury and workers' comp cases. And so so we bundled those surgeries for the docs and the facilities that we were able to contract with in New York City. And we, for the first time, made discount surgery available online for individuals. And we, with the partnership with WebMD, we saw our first patients and were able to prove the model that care and expensive care could be purchased directly at a discount rate outside of the insurance scheme, and done in with transparent pricing and without having to pay for insurance premiums. And so to me, that was an early dream come true, because people were talking about cash price surgery, like no one's pulled that off, yada yada. Well, yeah, we did, and I'll plug Techstars, because that was a huge help for us. We went through Techstars early 2023, and it gave us its accelerator, gave us a little boost in terms of our market power, and that gives some of the juice with the docs in the area, and we were able to prove and get those early wins. When that happened, I started to get inbound contacts from these small health plans, and I started to get a sense for the fact that the network that we were building, that the rates that we were securing, although they were enhanced rates, for doctors, we were paying docs in some instances 2 times what they were receiving from commercial insurance. Even at 2 times what their commercial reimbursement was still about half of what the employer was paying through their health benefit.
Well, that gives our audience an idea of how much the middleman is making, parasitically, if you will, off the doctors and the patients and the employers, right?
Yeah, I mean, yeah, it's a problem. I think that the amount of spread, the amount of markup that I've seen over the course of the last couple years, being taken by various middlemen in the ecosystem, is nothing short of evil. Those markups result in increased premiums because I'll take a step back. When you look at the core of the transaction, healthcare transaction, you have the care, and then there's the price for care, and then there's the total utilization for a member and the total utilization for a group. And that total utilization, it turns into or dictates the cost of the premium, the insurance premium, the monthly fee price that you pay into a black box, with the hope that that black box will then pay out when you need care. The more the price goes up, the more the premium goes up, the more expensive it is, and the harder it is for an employer or an individual to afford. And so when the price is going up artificially because there's a middleman who wants to take extract value from the situation and take advantage of the opacity and of the legacy systems that enable the opacity in the system, and when that results in people not getting the care that they need, and then their issues exacerbating, and people not catching issues early because they don't have money to access preventive care and take their meds. When that ends up in people getting sicker and dying, then that is a function of life or death. And so it's essentially, if you cut out all of the middle of the middle of the fat of what I just said, it's inflated prices is a matter of life and death. Inflated prices causes death. And so, look, I think that there's a way to do well by doing good. You're a doctor. I would say that you believe the same. And I chose to tackle the fat because I don't want people to face death because of this fake price. When I feel some and have felt for years some sense of obligation to address and combat that dynamic, because I know what things should cost, and I just happened to step into that space. Didn't want to be in it early on, but we don't always get what we want, and sometimes we're pushed into situations. So at its core, trying to make things cheaper, and we built the transactional infrastructure to manage insurance plans and bring transparency and give people visibility into their benefits and let them know what things are going to cost before they go. And really the transactional infrastructure that we've built that cuts out the middleman, it enables, it cuts out so much of the fat and so much of the inflated price that it gives people, it frees up a lot of what was otherwise going towards the premium, and it opens up or it allows for people to have or not have to pay, deductibles and copays. And so you're giving people access to free care, in the way of foregoing copays and deductibles for the first time ever, and we're able to pay doctors same day through our transactional infrastructure, because when an order, like you would put through ZocDoc or any appointment scheduling system, when an order is made by a patient, or when they could text in now because of our AI capabilities, you send in a text and you need to be connected with a provider. We're able to facilitate that through text message, and that order, putting the patient on the schedule and essentially authorizing the service as per the plan design, that pulls the money from the bank account, from the claims fund. And the money's sitting there waiting for the pre-authorized service, waiting for the service to occur. When the service occurs, we're able to drop those funds to the doctor, the facility, and in many instances, a multi-party, team, the care team, same day, based on, predefined rates. And so that, this isn't rocket science. Like, that's how it should be. And so, in short, that's what we've built.
So to sum up, you've got a system that costs patients significantly less money, costs employers significantly less money, all by virtue of transparency, that pays the doctors not just more than they would get paid through a conventional insurance model, but also more quickly. So instead of in 12 months, maybe it's in 12 hours or maybe even in as little as 12 minutes of when they've rendered the service. And the downside, I don't really see one. So the question then from our listeners who are doctors and doctors to be is, how do I get plugged in? How do they get connected to you so that they can get plugged in and take advantage of, participate in this win-win scenario?
Yeah, so it's super easy. Mishi.co//join join Mishi. Fill out the enrollment form and that'll initiate the process. Or you can text us 855-MISHI CO Mishi Co. Or call us at that same number, or come to the platform and chat with one of our care coordinators. We're always there answering anybody who comes on, and yes, you'll be met with our AI co-pilot Michelle. But depending on what's selected, you're connected with a live person pretty quickly. So it's super straightforward. But I would say, like you said, there are a number of different groups that are working to increase access or increase visibility and transparency and help connect individuals and providers with employers who are looking for this to facilitate this type of transaction. And I'm happy to connect anyone who reaches out with any one of our peers. Like you said, Demetrio, there are a number of groups out there and that are tackling the problem in different ways. You mentioned self-fund health and I spoke with them a couple of months ago. They take a big or put a big emphasis on navigation, and that's something that I didn't touch on in the context of what we're doing. But we have our care coordinators and navigators who are there to kind of guide you from step to step and eliminate the fear and complexity. But there are a lot of groups who are working to do the same thing. And we're, like you said, we're amidst a revolution where that's concerned, and there are a lot of exciting things going on. A lot of big names who are coming into the space and shaking things up, and bringing light and exposure to the issue and some of the things that are being done to resolve it.
That's awesome. Well, thank you, Sidney, for joining us today on the Direct Care Movement podcast. It was exciting having you on board. And if you're open to it, I'd love to have you back so we can dig into some of this a little bit more deeply. I know we did a pretty superficial, on 30,000 foot view because a lot of our listeners aren't as familiar with this. But I'd like to dig deeper into some of these questions, and I know you would too. So if you're open to it, I'd love to have you again.
Yeah, look forward to it. Welcome the opportunity. Appreciate the opportunity. Sorry, I got a little deep there, listeners, but I like to provide context because it's helpful to understand the surrounding situation to get a better sense of what's driving the problem. And so, yeah, looking forward to digging in and diving deeper.
Awesome. Well, thank you, Sidney, for your time. And thank you for the awesome work you're doing. We're excited to have you on board, and we're excited to see you, moving the needle when it comes to price transparency in healthcare. Thanks
so much, Demetrio. Talk soon. And thanks for doing this. Thanks for bringing exposure. Everyone who's listening, it's up to you to be the change and ride the wave of change. And I think we're one piece of it, but you guys are really what will drive meaningful and lasting sustainable change. So thanks for what you're doing, Demetrio.
Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.